after the first trimester, basically. So patients with macular edema can be observed, and the majority of them will resolve spontaneously. So there won't be a need to do some form of intervention as long as you note it. And it's important to also know that gestational diabetes is not a risk factor for diabetic retinopathy. If a patient never had diabetes pre-pregnancy, it's not necessarily an indication for them to come for laborious ophthalmic assessment. Intrapartum glycemic control is the best indicator of the fetal well-being than the grade of the diabetic retinopathy. So even if a patient has an extensive proliferative diabetic retinopathy, it's important that the management of the glycemic state is up to standard, basically. And then other risk factors, I mean, hypertension, I've already mentioned it, which is common in the type 2 diabetics, and it should be vigorously controlled. They recommend that at least it should be less than 140/80. Nephropathy, so patients with severe kidney disease, they're associated with the worsening of the diabetic retinopathy. And it's mentioned that adequate treatment, like let's say maybe kidney transplant, in those patients that warrant that, it actually also helps with improving the diabetic retinopathy, and it also helps with improving the response to the intervention of treating the diabetic retinopathy. Hyperlipidemia, it's also one of the risk factors, and there's studies that show that a positive effect on slowing progression of the diabetic retinopathy in patients who are taking statins. And the statins may also reduce the risk of developing macular edema. Actually, we have got people whereby like any patient who's diabetic, and even if they've got a borderline or normal lipid profile, it causes no harm to start them on a very low dose of statins. I think it's actually to their benefit. And then other risk factors that I mentioned are things like obesity, I think that we all know, smoking, cataract surgery. Actually, cataract surgery, unfortunately, in diabetics, it can be a predisposing factor, especially for the macular edema post-cataract surgery. So now the abnormalities that are associated with the loss of vision from diabetic retinopathy. So the first one being a capillary leakage, basically the diabetic macular edema. I'll just show a few slides of that, and the next one will be the patients, obviously, with that they can have capillary occlusion, and then with that they can have macular ischemia. And the sequelae of the ischemia, of course, we have abnormal vessels developing, neovascularization. They can get vitreous hemorrhages, they get retinal detachment, and neovascular glaucoma. So these are just, actually, this is one of my patients. Just for me to show, this is an OCT. So the first frame on your left, it's a fairly normal macular OCT. We're looking at the retina. So the
Hi,
first,
Doc.
sorry.
Yes, do mention what OCT is. Thanks.
Thank you. So OCT is one of investigating modalities that we use in ophthalmology. So it stands for ocular coherence tomogram. Because we don't have the luxury of doing retina biopsies. So they say OCT is the closest to giving us what histology will show you. So the picture on your left, it has two photos. So the one photo you'll see there's what are supposed to be vessels, that brown like wiring things there. Those are arcades coming from the optic disc, that black part. And then this is just a cross section showing us the layers of the retina. Where you find the dip, that's what you call the fovea, which is the center of which is central. It's centrally placed in your macula. So for us to have sharp Cribb's vision, the fovea is the most important part of that. Now, if a patient develops macular edema, like if you look at the screen on your right, that dip,
Yeah.
all
Yes,
right,
doc. There's a request that you must point. Thanks for that.
ish, you know,
Yeah,
actually,
with a
as I'm,
mouse. We can see it. We can see it with
oh,
a
you can
mouse.
see. Oh,
Yeah, if you can
thank you,
use your
guys.
mouse
I'm
on the
very
left.
sorry.
Yeah.
I'm very sorry. Okay, let me start again now. So the frame on your left, this is the cross section of the retina. So it's like a tissue cut, and the person is looking at it on a slide. But of course, with this, we're seeing it with our OCT machine. So this is how a normal retina should be looking like. Now, the picture on your right, where there's now leakage and macular edema, that dip is gone. One of my patients calls it the valley. Now you have a hill there. Uh, yeah. Are we good, doc?
Yes, you've got
Okay.
even positive comments on that. Thanks, doc.
Okay. All right. Sorry about that. And thanks for pointing that out. Okay. So that's one of the reasons, that's one of the causes that can make a person to lose vision. But interestingly, if the person gets treatment, the vision becomes restored with macular edema. Now I also spoke about macular ischemia. So this is a fundus photo of the right eye. So gosh, I think I should connect this to a mouse because I'm okay. Let's see. I keep losing my arrow. But anyway, if you look next to that disc there, uh, just lateral to it, the retina should look pink. That's a healthy retina, but you can see this one looks palish. So that's ischemia from, yeah, there, it looks palish. So that's ischemia. And unfortunately with ischemia, what's going to happen next is that the patient is going, I mean, the body is going to say, you know what, we need more blood supply, and then you get abnormal vessels developing, and the disease just goes south from here. So this is another this is another screen of just basically demonstrating ischemia. And then if you look, gosh, I keep, uh, uh, yeah. So this arrow here, actually, that's already pointed. That's just showing us a sclerosed vessel, a vessel that's already occluded. And obviously, if the vessel is occluded, what's going to happen? That area is going to undergo ischemia. It's gonna go ischemia. And so this is just a fundus photo, but it's also already showing us the abnormal vessels developing. These are like shunts developing. So this is already what you call PDR, and it's like moderate to severe when it's already at this level. Now, on this other side, this is just basically what you call fluorescence angiogram. When we put fluorescence in your bloodstream just to locate where the occlusion is, but it also shows us when you want to measure the amount of necrosis. So this is already, you're seeing that that area is already kind of necrotic or ischemic, let me just use the right word, yes. Peripheral to the obliterated vessel. Nice. I think on this no on this frame, I just wanted to show um, patients with neovascularization, where like you have abnormal vessels developing, and gosh, and with those abnormal vessels developing, you end up having retinal hemorrhages. So this is some form of proliferative diabetic retinopathy as well. And it's obviously the one that we say you're falling under severe form of the diabetic retinopathy. So patients also get what you call vitreous hemorrhage. Now, this one, it's a vitreous hemorrhage, but you see it has a particular pattern. We call it, it's boat shaped. So it's a subhyaloid hemorrhage. So they bleed from these abnormal vessels. And this subhyaloid hemorrhage, commonly, it will be right in front of the macula. And it's usually sight-threatening. And usually most of these patients, they'll end up in theater because they'll need what you call a PPV, but I'll come to that as well. So this is another frame just showing us a vitreous hemorrhage, which is just in, my pointer is, yeah. So yeah, basically on your right there, you can see that exaggerated bleed. It's what we call preretinal hemorrhages, and it's obviously part of the vitreous hemorrhages. The severe form of the disease, patients will develop what you call tractional retinal detachment. Now, yeah. So as you
Hi,
can see,
Doc.
yes.
Let's try to get the PowerPoint, what you call pointer.
You know what I can
So
do?
if you move
The light
on your left lower corner, if you move your mouse towards your left lower corner, where there was these buttons for moving your slides, I want to show you how to pick up a pointer.
You know
Just
what, Doc? I was
yeah.
actually, I was
Okay.
actually, I was actually not using a mouse. Let me connect the mouse and see, because I was just using. Uh, let me
Oh,
see.
okay. I wanted to show you the better way to select the pointer. Click
Yeah,
anywhere on.
yeah. I'm just worried about the time. Yeah,
Oh,
so
okay. Okay, no,
yeah,
it's
I
fine.
think
Yeah. All right,
yes. Hey,
sure.
guys, excuse me. I'm very sorry. I'll get it better next time. So yeah, so this is the split. This is the neurosensory retina. This is the part of the lower part of the retina. So this is an OCT picture of end-stage diabetic retinopathy. This is the patient that I saw recently after she was seen in 2021 and unfortunately disappeared. And now this is the end stage of the disease, uh, where we can still intervene, but the prognosis is really guided. But I just wanted to show you those frames. Now we've got a mouse. I think the next pictures will go in smoothly. Uh,
Awesome.
so this is uh, neovascular glaucoma. So how do we get to see neovascular glaucoma? We have iris vessels. So any normal iris is not supposed to be having vessels like this. So we usually count them in clock hours. So you can see, I mean, you can see this is at least 8 clock hours. And with these vessels here, they also develop vessels in the angle, these abnormal vessels. And usually that gives us what we call neovascular glaucoma. And it's part of an end stage of proliferative diabetic retinopathy. It's actually regarded as advanced proliferative diabetic retinopathy. And the prognosis here is really, really guided because now they end up with a very raised intraocular pressure that's very difficult to control. And if they have vessels here, you can imagine the back of the eye. It means it's vessels almost everywhere. Now, how can we prevent uh, diabetic retinopathy? I think it's crystal clear. Intensive glycemic control is the top one. And this is done by us, clinicians, basically, with the first line, the people who see these patients. Because if we have this well controlled, already all those sinister pictures that I've shown you, we prevent that. Intensive control of blood pressure. And I mean, I must say that these two, it's only not us, the clinicians, who are responsible. The patients are also responsible. I always say it's a team effort. The coach can do the best they can do, but if the player is not listening to the coach, it's a problem. And intake of statins, it's been proven. There's a few studies. Lifestyle modification, smoking, drinking, or should I say moderate drinking at least. And then early involvement of other disciplines. For example, young females, when they start saying, I want to plan falling pregnant and they're diabetic, it should start there. Young children, like, the type ones, whereby like a child has been diabetic from the age of 8, 9. By the time they hit puberty, it's associated with extreme rapid progression from just non-proliferative to proliferative. So you don't want to miss this window period. And hence, that's why I'm saying the screening guidelines should be emphasized to our patients. Like, for example, a type 2, they should be screened appropriately on time. Type 1, when you should start screening them. And already I've mentioned the prevalence. I mean, we know that, and those risk factors in terms of the duration. Now, I'm going to touch on the treatment, but I felt before I go on treatment, it's just to remind our colleagues about the basic anatomy of the retina. The inner layer, this we call it the neurosensory retina, and then beneath this one that is hyperreflective, we call it the retinal pigment epithelium. So these two, they have different functions. But of course, the neurosensory retina is the crucial part for us to be able to perceive vision. And with that, obviously, we also go to the retinal vasculature. So from the optic disc, the central artery divides into those arcades, superior and inferior arcades. It divides into 4, basically. And then these vasculations, of course, I mean, from there you get arterioles and up to capillaries. And the capillary plexus, actually, it's in 2 forms. We have the inner one, which is more around, it's in the, they say it's in the nerve. It's more, it's in the in the ganglion nerve layer. So it's in some part of the neurosensory retina. And then there's the outer capillary plexus as well. So both those capillary plexuses, they actually come from directly from the central retinal artery, and they supply 2/3 of the retina. So I think the other one, the chorocapillaries, I don't need to mention much. What's important is the capillary plexuses that is coming from the central retinal artery. And now coming to the pathogenesis, it's complex, but there's certain hypothesis. For example, the extended exposure to hypoglycemia itself, that it basically it stimulates production of a whole lot of inflammatory markers, your oxidative stress, your protein C kinase, and a few other ones. And then these inflammatory and that biochemical imbalance on its own, it actually destroys the endothelium and also destroys the pericyte. So pericyte is part of the I would say the layers of the capillary wall. And secondly, microvascular occlusion. So the reason I'm mentioning this, because when I talk about treatment, you'll be able to follow that this treatment is uh, basically trying to intercept this part of the pathogenesis. So microvascular occlusion and leakage, I mean, that I suppose it obviously makes it kind of sense. But then what causes this occlusion, microvascular occlusion? There are some hematological changes. Like, your red blood cells, they become abnormal. They call that Roulet effect. And then you have capillary changes where the capillary wall itself, you have endothelium thickening and loss of your smooth muscle, and that on its own, it promotes the occlusion. And then once we have the occlusion, what will happen? There won't be enough blood supply. You get hypoxia. Hypoxia, the tissue gets ischemic. Now, once we reach this part, what happens? We have an increase in angiogenic factors. So basically, these are things that stimulate development of vessels, but basically these will be abnormal vessels. And the main angiogenic factor that has been studied, we call it vascular endothelial growth factor A. So our treatment targets this angiogenic, this vascular growth factor A. But there's many others that are coming, there's a lot of research that's going through about other forms of VEGF except A. Now, once we have the stimulation of these angiogenic factors, we have abnormal vessels developing, arteriovenous shunting. And then when that occurs, basically there's a shunting between the arterioles and the venules. And in between that space, there's areas that are not having blood supply at all. And that's obviously promoting to the to like necrosis of the retina. Now we have this new vascularization. I've already mentioned that as well, AV shunting and that because of the stimulation of the vascular endothelial growth factor A. Macular edema, so this is cystoid macular edema. So macular edema is obviously due to the extensive capillary leakage. And then because these vessels are obviously abnormal, so they leak very easily. And then they cause that heel that I was mentioning earlier on. Now, how do we treat diabetic retinopathy? Macular edema, as I've already mentioned, it can happen in any stage of the disease. And we have treatment that works. We give them what you call intravitreal anti-VEGF, anti-vascular endothelial growth factor. So I'll just say anti-VEGF. It's the first line of treatment for macular edema, and patients respond very well. But now, some patients might not respond to the first line treatment. We go to the second option, intravitreal steroids. I just mentioned two that are commonly used. And as I already mentioned in the pathogenesis, we have increased inflammatory markers. It's not surprising why some patients, they won't respond to anti-VEGF, but they'll respond to steroids. Actually, some patients, they'll even go on to respond to a combination of two, but that will be another discussion for another day. And then some patients, but this is, I must say, it's no longer used when we do a focal PRP, especially if ever the patient has a focal macular edema. But if they've got a diffuse macular edema, we use grid PRP. But as I'm saying, this is no longer the practice because anti-VEGF has really changed the management of these patients to a far much better outcome. Because this PRP is laser, so it's also destructive to the tissue as well. And then non-proliferative diabetic retinopathy, most of these patients, they won't need treatment unless they've got non-proliferative diabetic retinopathy together with diabetic macular edema. So once they have those two, then they'll also benefit from intravitreal anti-VEGF, you know. And then we can also use it for patients with very severe or very severe form of the non-proliferative diabetic retinopathy. Because I won't go into the stages in terms of what do we look for to say this is severe, this is not severe. But I just think for the purpose of the discussion, it's important to know that the earlier we get with the disease history, the better. Now, what do we do for patients with proliferative diabetic retinopathy? The first line of treatment is still PRP laser. How does this laser work in terms of what does it do to the eye? Basically, it ablates these abnormal vessels that are supplying the necrotic tissue. And for some reason, when we do that, it can actually more often than not, it will regress as if we pick it up in time. But anti-VEGF, it's still a safer alternative to first-line treatment. And the nice thing about anti-VEGF as well is that it actually works quicker than PRP laser. I mean, within a week, you expect to see changes when you repeat your OCT scans in these patients. Or when you basically examine them, within a week, you expect to see some form of changes. And then there's also a lot of room for using both anti-VEGF and laser, especially in patients who have this severe proliferative diabetic retinopathy together with macular edema. But in some patients, we might have to go in where we call it the PPV, a pars plana vitrectomy. So these obviously, nobody will refer them to our vitreoretinal surgeons. And obviously, they also don't like treating this end stage disease because the prognosis is really guarded. But I mean, when is it indicated? If a patient has extensive vitreous hemorrhage, or if a patient has bilateral dense vitreous hemorrhage, if the patient is not responding to the PRP, if it's an only eye, let's say one eye is blind, you really want to obviously be slightly more aggressive. Now, I've already been mentioning vitreous hemorrhage, so I thought I must also talk about how we manage vitreous hemorrhage. So there's this study called the Diabetic Retinopathy Vitrectomy Study. Um, what it looked at is that type 1 diabetes mellitus with severe vitreous hemorrhage, they showed benefit from earlier vitrectomy. Type 2 with severe vitreous hemorrhage, they can be observed. We can observe them monthly for 6 months. And we hope that as they control the hyperglycemia, they change their lifestyle, we hope that the vitreous hemorrhage can regress. I don't have the stats on that, but quite a few of them, they end up with a PPV after all, with basically with surgical intervention. Now, what we look at when they look at the study, they also looked in terms of did the patient receive laser treatment, what we call that PRP laser treatment. If it was done, okay, let's say if not previously done, then earlier surgical intervention is recommended. But if it was previously done, you are justified to observe them as long as you see them monthly. I mean, that's very important. And in every visit, we do what we call an ultrasound. We do a B scan, this ultrasound, and then because now our things like OCT, they can't. Uh, they are not very effective if a person has a dense vitreous hemorrhage, basically, in terms of imaging as far as to show the retina. But we do the ultrasound just to exclude retinal detachment. Because on a B scan, you'll be able to see that basically on an ultrasound, you'll be able to see if ever there is an associated retinal detachment, and then you'll have to go in. Uh, so now, in conclusion, I'm just going to present two cases. I'm not, let me see, time, yeah. I'm just going to present two patients. Um, so let's go back there. So this is a patient who was seen for the first time in 2021. She's in her mid 70s to late 70s. So this frame here, it was when she first presented. And then this is of the right eye. So that right eye had hand movement vision. So the left eye, she had vitreous hemorrhage. So hence, like I was saying, we couldn't do the OCT for the right for the left eye. It couldn't be reliable. And treatment was given to her. We basically we went all out, gave the anti-VEGF for the hemorrhage on the left eye, booked her for a pasplantar vitrectomy because she's got traction retinal detachment. If you remember, I did mention the indications for surgery. If there is a retinal detachment, we have to go in. Unfortunately, this lady in 2021, the history was that she's been diabetic for 30 years. She disappeared. She never came back. And I must also add that on the day when she presented, that right eye had some form of vision, even though it was like count fingers, but that's better than nothing. And on the left eye, she had only light perception. So she was booked for overseas surgery for both eyes, and she never came. I saw her in January this year. Uh, gosh, I don't know if I'm trigger happy here. So I saw her in January this year, and unfortunately now, one eye is completely blind. The other eye, we did a cataract procedure for her. And when you look at the back of the eye, this is after cataract surgery because on the day when she came, we couldn't scan her in any way because the eye was in bad shape. So we really couldn't get any imaging from her. So going back to this patient here, now the retina, if you can see, you cannot even see much of it compared to on this scale that she came in 2021. So that's why I'm saying sometimes education from us, even myself included, to say to emphasize to the patient that this is important. If there's issues with funds or whatever, here's a referral letter, but you need to. But we still have colleagues in the public sector where like you can say I can make a phone call to arrange. You say, can this patient be seen urgently? Because it's not nice to for a person to lose vision, like I say, from something that can be somehow salvaged. But I think in her case, it was already towards the end of the disease. Now, this is my second case. This gentleman is a 56-year-old patient. 2023, June, he underwent cataract surgery in both eyes. Come September, on our follow-ups, he's a diabetic, by the way. Post-cataract procedure, everything was fine. We were happy. Visual acuity was 6.6, 6.7, on the right and the left. So that's like a good outcome. But 3 months later, she developed, I'm sorry, this scan here is not the same as the others, but this is our retina. The deep is gone. There's a hill, so there's a leakage. And he was unfortunate. He developed on both the right and the left eye. But then we went to our anti-VEGF treatment. We gave her the injection. He came back a month later. And by the way, these procedures are office procedures. These intravitreal injections, these PRP lasers, they are office procedures. And we just make patients to be comfortable, and pain is definitely not a big issue. So this is a month post the first injection. This is now in October. As you can see, the right eye, the dip is back. Mr. V is happy. The vision has gone back from being 6.8, it's now 6.9, 6.6. And unfortunately, the counterpart, the left eye, the heel is still persisting. So the teaching tells us that, you gave anti-VEGF already, but the right eye improved. Let me give another anti-VEGF and see what will happen. So we do another anti-VEGF for the left eye only now, because the right eye we know it has resolved. Now on the right eye, we can see the dip is still there. This is another modality whereby like we like showing it to patients to show them that there's progression, there's improvement or what. But in the left eye, the heel is still there, even though there is that green color. So when you see green, it's basically showing us that it is going down. But it's 2 injections, still no improvement. What did I do? I go to the second line. So we gave this patient intravitreal triamcinolone. We gave him a steroid. And it was multiple steroids, I must say. Probably gave him one full cycle. So a full cycle is like 3 injections. And steroids, instead of the anti-VEGF, we give them every 6 weeks. Anti-VEGF, we give it every 4 weeks. Now, the last time I saw this gentleman last year, this is where we were. When we started the treatment, this is where we are. So now the retina is normal, the macular edema is gone. And the green is showing us that it has gone down by quite significant. Basically, we were both happy. Me and the patients were happy. Me and the patient were happy. And yeah, I think I'll stop there, but then just say maybe in conclusion, it's crystal clear that early intervention, I guess like with any other disease, is very crucial. But patients really get what we call irreversible vision loss from something that shouldn't be happening. I know there's other bigger problems. There's financial issues. Patients sometimes they don't even have taxi fare to go to the hospital. But I think we need to emphasize to our patients that we want them to keep on having crystal clear vision. Doc, I think I'll end it there.
Awesome, awesome. Colleagues, let's give my dearest dog Mofokeng all assorted thumbs and hugs and everything. From me, you get the horn, dog. Vuvuzela.
Thank you, thank you, thank you.
It's yours. Yeah, I mean that was very, very, very awesome and empowering. So I really, really want to thank you for that. We have a lot of questions to go through. So yeah, I think let's get ready for that. You can stop sharing, Doc, from your side if you are able to, so that
I'm able
colleagues
to. Thank you.
yeah, so that colleagues can see you. Yeah, there we go. There we go. Colleagues, obviously, there's like before he even finished, there was already 30 questions or something like that, 14 questions or whatever. So let's go and see how far we go. I had my own questions, but I think let's stick with what the colleagues are saying, and then I can chip my questions if time allows. So Angie
Thank
was
you.
asking there, are you saying those who are insulin dependent are more at risk of proliferative disease compared to the non-insulin dependent patients? And maybe the
Uh,
key question from Angie is why would that be the case? Yeah.
okay. Um, Thank you, Angie. So basically, the patients who are like the type 2, who are non-insulin dependent, we screen them earlier because of, by the time we see them, there might be some form of disease. But those who are insulin dependent, whether it's type 1 or type 2 or insulin dependent, it somehow follows an aggressive course. Uh, I think the reason being probably, uh, with the type 1, that on its own is an aggressive disease, and maybe controlling it could be an issue. Like we say, that the risk factor is control and the duration. But with the ones that are on insulin, who are insulin dependent, it usually follows an aggressive course to being proliferative. And I think maybe another reason as well, and it could be that, with type 2, there's always an association with hypertension and this and that. And, if all those things are controlled, they don't progress much. But those who are insulin dependent, not clearly known why, but they definitely follow an aggressive course.
Awesome, awesome, Doc. Casey is interested to say, so after showing us all those treatments, which ones can the GP manage? But actually, basically, Casey is asking, what is the job of a general practitioner in diabetes retinopathy? Is it just to refer patients, or there's something else? Yeah.
Casey, I, I- uh, I'm not sure when you joined the discussion, you are aware that actually I'm a GP at heart, because in my career path, I was a GP for longer than I've been an ophthalmologist. And the best thing, we don't want to be treating diabetic retinopathy. Let's start there. So the GPs play a crucial role in adequate
Yeah.
control. Like I said, the operational way there is intensive control of the glycemia, intensive
Mm,
control of the hypertension. But once they are,
mm,
once let's say we follow those risk factors and they are referred appropriately. Unfortunately, GP will never be, shouldn't be giving an injection to the vitreous. Unfortunately, even this
mm.
PRP, we need to have one. It's one of those expensive devices, but you also have to go through the training of applying it. I think any doctor can be trained to do those procedures, because I did them when I was a medical officer, but I had to go through a training. So I could still say I was still a GP, but I was working under supervision of ophthalmologist. So if a person is doing this thing under supervision of ophthalmologist, definitely. But is it safe to do it in your rooms? If you can reassure sterility, and yeah, I mean, and you underwent appropriate training. But you know what?
Mm,
I don't want to get into trouble with this, but I feel it's a bit of a tricky one for now.
mm, mm. Yeah, thanks, Doc. So Ntogozo is asking, about the early warning signs, and maybe the way I'd put it, we always have these ophthalmology nurses. We don't usually generally have ophthalmologists. I think there's an access issue because I think I saw there's comments about waiting periods and those kinds of things in the public sector for some of the procedures. But Ntokozo is asking, are there early warning signs of this retinopathy? That from a nursing perspective, from a primary healthcare perspective, I think you can emphasize more on prevention, but if there's any other things that can be done at that level, you can recommend, Doc. Thanks.
Unfortunately, like I was saying, a patient can have a background diabetic retinopathy and still have perfect vision. So by the time we see signs, it might not be the best time. So that's why I was emphasizing and even putting those studies down of the screening protocol is to catch them early, to say, you know what, people have to go for screening. Because most of these patients, they'll have what we call non-proliferative diabetic retinopathy, and their vision is perfect. And hence, that's why we don't intervene. But we note it so that we know it has a natural history that you can follow if a person is not stabilized in terms of the glucose and the hypertension. So early warning signs, no, they aren't actually.
Is that the screening which is important? And I don't
That,
know,
mm,
from a midwife perspective, if you have a pregnant lady who had diabetes pre-pregnancy, the question is, are you referring them for eye screening checkup? Because that's what I got at least. Because Mtokozo says, as a midwife, my understanding is that you are more worried about patients who had diabetes before they fell pregnant, and they at least need to get one eye assessment. Am I correct, Doc?
yes, you're correct. Ntokozo is correct as well. Uh,
Yeah.
yeah, but we know that if a person is well controlled
Mm,
pre-pregnancy, even though they're diabetic, chances are they will never develop diabetic retinopathy. But it's very important to at least have a baseline assessment during the early
mm.
first trimester.
Okay, awesome. Some of the questions, maybe you'll make sense of them because Anonymous says fluorescence in the bloodstream or via the eye drops. I can't remember
No,
what
I,
you were
I know it
talking
makes
about.
sense for me. It
Yeah,
makes sense.
yeah.
Yeah. So, in ophthalmology, we use fluorescein a lot for different reasons.
Yes.
But in this instance, the slide I was talking about, it was when I was saying if you want to assess the amount of ischemia. So we actually put fluorescein intravenously, but obviously we prepared in a certain way for it to be safe to be given intravenously. Personally, I don't necessarily like it, but it's still an important tool because now we have advanced OCT machines with something called an OCT angio. So this is non-invasive in terms of you don't have to put a drip, but it can still give you the answers that you need. But the one that, yeah, that fluorescein will take it into the vein. And of course, whatever you put in as an IV line, it can have side effects, but they are very rare. I mean, unnecessary side effects, even death can happen,
Awesome.
anaphylactic reaction. Yeah.
Awesome. I think many people commented on your comment about the use of statins as part of the prevention program. And I don't know whether you are the right person to talk about the dose and how was I don't know if it's the physician's role. I mean, you only
Um,
see them when there's problems, generally. I don't know.
Yeah, no, 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 no.
Yeah.
But actually, I think I can have a small input.
Okay.
Actually, I think my colleagues will have even more input. The slowest dose available. I'm not sure that this ASPA voice is five. Okay, I don't necessarily mean to promote that. That's one that I'm familiar with. I think the slowest dose is at 5 milligrams, but the slowest dose available, as long as we know that this person is diabetic,
Mm,
he has borderline lipid profile, you can start them safely on the lowest dose available. So not a therapeutic
awesome.
dose, a
Mm,
prophylactic dose of some sort, if I can put it like that.
yeah, awesome. So this question by Anonymous, because I was following in the chat, someone had posted that why do people who had their cataracts removed, why do they have a repeat cataract? And then someone said, no, the second one is not a repeat. it is this posterior capsule opacification. Then there was a direct question then to say, how common is this posterior? So maybe you need to comment on recurrence of cataracts and then the post capsular opacification.
Okay.
Yeah,
All right.
in that space.
Yeah.
Yeah.
Yeah. Okay. It's a good question actually because patients always ask, does a cataract come back? No, it doesn't. But in almost all our patients, especially diabetics as well, you're doing a surgical procedure to the eye, the body is going to release a inflammatory response. So those cells, they accumulate behind the capsule. That's why we call them posterior capsular opacities. So, people have their own protocols. For me, standard, all patients after 3 months, after they've had a cataract procedure, there will be some form of posterior capsular opacity. We just do what we call a YAG laser capsulotomy. It takes about a minute per eye. It's done, it's an office procedure. You basically break that opacity with some form of laser. And I think so. What happens is that maybe patients were not being explained to. So if a patient comes to you, doc, and says, I had a cataract operation done, but it's back, it's not. It's a PCO and it can be treated. And I think with diabetics, it could be more common, but I don't have any confirmatory studies.
Awesome, awesome. Then there was a whole lot of questions when you got to treatment about availability of those treatments in the public sector. Firstly, I don't know. I wish you knew what is the rate of, I don't know, one ophthalmologist for per what population, that kind of a thing. Because there's an issue. It seems like you guys are very rare. But there's a question about availability of your treatments in the public sector. When you're at vets, at least during your registrarship, the proposed or the treatments you have shared here, are these available in the public sector? And also affordability in the private sector?
Um, I think I don't want to get into trouble with the public sector because clearly some of my colleagues are tuned in here and judging from the way they could answer about the PCO. So
Uh,
it's a general problem, even not just the vet second hospitals. I mean, before I could get a reg post, I was in one of the smaller hospitals. I won't mention the name before I get into trouble as well. Uh, we, we 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 are overwhelmed. I mean, you find that. So unfortunately, I won't be able to answer the requirement in terms of one ophthalmologist per. I should be able to, but I guess I didn't look into it. But I'm supposed to be able to know that. But now that I don't write exams, there's certain things I don't read anymore. But it's important I should be knowing that, I must say. And I'll get back to you guys about in terms of that ratio. But that's why we always have what you call even in our clinics, we have what you call screening clinic, whereby like patients walk in, they are referred from Dr. Mofokeng from Togoza, Dr. Mawela from Sama, they're referred there. You read the referral letter, you should be able to say, you know what, this patient must be seen today. This patient must be seen within a week. This patient must be seen within a month. We do have processes. The unfortunate thing is that within those existing processes, there's loopholes. There's loopholes because at the end of the day, I mean, due to my rush time, I mean, I know sometimes you leave the clinic at 5 p.m. I mean, you're supposed to be there until 4, you know. But having said that, it's not a lie that you also have colleagues who want to be out of there before 4. So, it's also kind of a management issue as well. But I think we should be able to say this is an emergency, you know, and part of it is to also reiterate amongst our colleagues to say, you know what, if this patient is type 2 diabetic and he's been diabetic for 5 years. So I think maybe the onus is also on us as the referring clinician to say, patient Mofokeng, type 2 diabetic for 5 years, never been screened before. Please arrange for diabetic screening. And then, we've got ways of saying, okay, can I quickly assess the vision of this patient? The vision is still kind of very intact. No, I can see this patient within 2 months, within a month. Unfortunately, that one, it will take a while to fix it. And you're right. I mean, in hospitals, ophthalmologist department are kind of they are regarded as a non-emergency department. So it's a bigger problem. Doc, I'm not sure if ever you can hear me. I can't hear you. I
I'm
couldn't hear
busy reading
anything.
a question.
Oh,
Yeah, but I was muted. Yeah, sorry. Yeah. So Exen was asking about the prognosis of progressive diabetic retinopathy, where a patient is taking equatrin and clopidogrel gel. I don't know if you had this in your slides, this regimen. Maybe comment on the regimen if it was there, and then if it's something that works.
you know, I'll be honest with you. I didn't have anything about like that on the slide. But what I know is that, I mean, Ecotrim is some form of aspirin, isn't it?
Mm, mm,
Yeah. So unless if there's recent publications, so far, I mean, even according to American Academy, there's no benefit. Patients
mm,
didn't show any benefit, those who are taking aspirin. As much as
mm,
we mentioned hematologic causes, where we know that there'll be platelets causing accumulation, there'll be the relay effect from red blood cells. So basically, there'll be clots, but aspirin didn't show any benefit. I haven't come across any
mm.
study at the moment.
Okay, awesome, awesome.
But that's a
And
good
then
question, I must say.
yes, and Linda was thanking you for an awesome presentation. So these injections you are referring to, how long exactly should people get them? And yeah, and does the condition eventually heal? Do you get? But I think you had two case scenarios with good outcomes, especially your second patient, I think. But
Yeah.
yeah, your comments.
Um,
We might have lost
so,
Doc.
so
Oh,
yeah, so
okay.
basically the duration, you know, in most of these studies, where this because most of these studies for treating diabetic retinopathy, actually they usually go for 2 years. People like patients are getting treatment for 2 years, but we have to use real-time studies as well. Uh, if the patient was caught early, they resolve. They resolve, and if you maintain the normal glycemic state, they resolve. But you have to continuously monitor them because it can recur. You know, uh, the treatment, like I say, if ever is patient is started treatment early, the intervention is done early, it really works. It works wonders. Now, there's newer anti-VEGF injections that are on the market. I just didn't want to go deep into that, but that's a discussion that we have amongst colleagues. Commonly now we use Avastin. I'm not supposed to be necessarily promoting that, but that is what is commonly available for us. It's slightly cheaper compared to other anti-VEGFs, like there's others like aflibercept, which is almost 3 times the price of Avastin. So these injections are given monthly. Now the newer ones, from the top of my, there's one called faricimab. So this one, it really works well. I mean, they even claim that you can give it every 3 to 4 months per patient, like per cycle. So one injection, 4 months. Some people even say we can even give it 6 months. And like I also mentioned, Ozurdex. Ozurdex, we can give it for at least like 6 months, 6 months um, cycle. The only problem is the battle with the medical aids. Oh, I don't know how many motivation letters we write and they get rejected, and you submit high impact studies. But yeah, that's a battle we are having. But that's that's obviously cost issue. So there are those that and of course, just to answer the question, for me, the regimen that I follow, I give you the injection until the if it was for macular edema until it settles. So on the last visit that I see you for the first time that edema is settled, I give you one last injection. So basically, it's like something you treat and extend, and then after that, I say I'm gonna see you every 3 4 months and hope it doesn't recur. And if it recurs, patients usually know. They'll tell you, doc, I know my appointment is in August, but I came because I'm seeing some changes. Patients usually will tell.
I think this follow-up question or this question is important. So, because I think Babegil is actually asking when exactly should we or how often. So, let's say someone is diabetic and we're talking prevention and initial assessment by an ophthalmologist, and then the follow-ups. So when exactly, what is the preferred schedule or recommendation around that? Which patients, I don't know, how does it work?
Okay. I think
Yes.
the first thing that you look at is looking at your risk factor. We mentioned the
Mm,
duration. Any type 2 diabetic, if he has never seen an ophthalmologist or anyone who can examine the fundus and determine if ever, because I mean, it doesn't have to be an ophthalmologist, as long as the services of ophthalmology in that hospital, even the medical officer will be able to assess that there's any form of diabetic retinopathy. Anyone with type 2, they need a baseline assessment. Type 1, if it's type 1, the Americans say you can wait for 5 years, but I can tell you now, in our South African context, I'd rather have them seen earlier as well, even if it's just one visit. And if he's not
mm.
there, you can say, I can see every 6 months, I can see every year.
Okay, so I think that is fine. Colleagues, we're going to take the last two questions. We are way behind time. Where this channel, this specific channel, has to transition to the Diploma Child Health colleagues. If you see me looking left and right, is because we've got the part one obstetrics on my left hand side, and then we have the diploma obstetrics on my right hand side. And this channel, when we finish, the child health colleagues are waiting for us. So someone is asking about the private health sector. Is Timothea, and how do you get the other disciplines to work with you? What models are you using there? Because these patients might need a podiatrist, they might need a surgeon for this, they might need a nephrologist. So the care coordination to encourage a multidisciplinary approach. Yeah.
Yeah, in private practice, okay, in the place where I work, we already have uh, colleagues that we work close with because some of the referrals are coming from them, some of their referrals coming from us. I mean, I found the practice existing for the past I don't know how many years now. So, but they already have system in place. But I mean, it's not like a written protocol system. But I just know if I get
Hi,
Dr.
Valerie. I think when you're ready, you should start. I'm still in another webinar. Thank you.
No worries, I'm gonna share.
Okay.
Oh yeah, yeah. So basically, I do have a few colleagues that are on speed dial, literally.
Mm,
Mhm.
okay. Okay. I think most of the some of these we have already responded to. At which stage of pregnancy is it more accurate? We said if they have a pre-existing disease, we should do that. So maybe we'll take one of the questions that I had for you. You kept on referring to intense control, intense
Mhm.
control.
Mhm.
How do we get there? You are the Minister of Health, Doc. You
All
have
right. So
policy changing powers. So,
yeah, no, but I suppose this thing of intense control, what they were looking at was saying if a patient is type 1,
yeah.
uh, they must start on insulin, don't play around. That's what this intensive control is. If a patient is type 2, do you say lifestyle modification first and hold the treatment, or do you start them on treatment? So intensive control, if you start them on treatment, less intensive is if you start them on lifestyle modification. And a few of patients will get it right of type 2s, or like maybe the so-called pre-diabetic. But obviously, we know in our setting, it can be for me, I won't be able to sleep at night if I say to a person, lifestyle modification first, knowing what I know now.
All right, those colleagues. I mean, I enjoyed this session. Like I said when we opened, the eye has always been very intimidating. At least now, from a diabetes perspective, there's few things that I can start doing correctly for the patients. And Doc, we really, really hope to connect with you and have more sessions on the eye. I actually saw a comment. I thought I had highlighted it. Someone was saying the master class. Something is agent. I can't remember who that was. I think it was when you were teaching, and we were all realizing, okay, we are a bit outdated in this space. So yeah, just to say thank you very much for your time. I know what it takes to prepare, and for a specialist to still have time to prepare and come and teach us. I can never take it for granted. Your closing remarks, and then we call it a night. Thank you.
Uh, I think I just want to thank you, to thank everyone who made time to listen to me, because I mean,
Mm.
like you're saying, we work hard and then we come back home, we still have to work the kids, the exams. So I mean, it really is humbling for people to
Mm.
make time to listen to this, because it's a topic that's very close to my heart. So
Mm.
that's my closing remark. Otherwise, let's let's let's
Yeah.
let's take off these patients. We are their custodians when it comes to their health.
Thank you. Thank you. Thank
Mm.
you. Yeah, colleagues, that's it for the night. I've been sharing the link for membership. If you are here and you are not a member of the platform, I'd love to encourage you to join us on this journey so that we are able to continue to bring you this educational program. Just click on the link, read what we are all about. If there's an alignment between your goals for growing daily and our goals for helping you to grow daily, please join us on this journey. On that note, night, colleagues. I'm crossing over to the child health colleagues. Doc, we will catch up via WhatsApp later. Thank you. Bye, colleagues.
Bye.